making you and Sandeep the co-host, so it will be not a loss of this meeting again. Okay. So, dear friends, sorry for the interruption of the technical glitch, and we will start our program straight away with the short introduction of AACCI, followed by our introduction of our own today's esteemed faculty. As we all know, our holistic mission of the AACCI is to the holistic health of the child and young adult with the promotion of the healthy lifestyle and prevention of the lifestyle associated disease. And today, our two speaker is definitely going to speak about the one of the most important part of the our healthy lifestyle, and that is about the sleep. And that what we majority of the time we are slightly neglecting about the sleep and its related problem. And for that purpose, today's discussion is very important to understand what it means. And for that, we have get two esteemed faculties, Dr. Barbara Felt and Dr. Deanna Pennewitt from the Michigan University. Giving the short introduction of the that, Dr. Barbara Felt is the MD and MS and professor in the Division of the Developmental Behavioral Pediatric and Program Director of the Developmental Behavioral Pediatric Fellowship Training Program at the University of Michigan at Ann Arbor, Michigan, USA. She has practicing since 37 years in the clinical interest in ADHD, sleep disorder, and elimination disorder. Has 71 publication in her name. Second speaker will Dr. Deanna Pennewitt. She is a third year fellow in developmental behavioral pediatric program at the University of the Michigan Annie Bot MI. And she is also having a keen interest in the sleep disorder. With short introduction, I hand over the mic to today's esteemed speaker to make their presentation starts. And anybody having any question, please put that into the our chat box. We will take it in the end of our presentation. I also welcome my co-host Dr. Sandeep Kavade to take the care of the all the chat related queries, and he will take all the details in the end.
Hello, thank you all for having us. So today we'll be talking about pediatric sleep problems. So starting off, non-disclosure, neither Dr. Felt nor I have any disclosures to report. Our basic kind of plan for this talk is we'll first start talking about just a refresher of sleep basics, including sleep physiology and recommendations for sleep. Then we'll talk about some common pediatric sleep problems. Then we'll talk about some behavioral sleep supports, as well as talking about some in-clinic screening that we can do for sleep problems. So first, why do we care about sleep? We care about sleep because it's an active dynamic process, has a critical impact on many aspects of health, daytime function, and development. Inadequate duration and quality of sleep, as well as a misaligned circadian rhythm, are associated with a number of cognitive and behavioral consequences in children and adolescents. And insufficient sleep, and so there are a variety of these. Insufficient sleep can impair emotional regulation that can lead to irritability, decreased mood, and less self-control. It can also lead to increased feelings of sadness and anxiousness. It can also lead to behavioral problems. So motor hyperactivity is consistently reported as a consequence of many different sleep disorders. In fact, there is an overlap between symptoms of ADHD and sleep disorders, especially obstructive sleep apnea. And this can lead to increased risk-taking behavior as well as other behavioral disinhibition. Poor sleep is also associated with learning difficulties. It's associated with poor executive functioning, impaired attention and memory, and thus can lead to a decrease in grades. And then, in addition to just the behavioral and cognitive consequences, poor sleep can also have a negative effect on just health in general, including increased risk of heart disease, diabetes, obesity, high blood pressure, as well as higher immune functioning. In fact, there's evidence that that when there is poor sleep in the short term, there can be increased infections. So I wanted to share some sleep statistics, so we're kind of seeing where we're coming from. So in a study published in 2024 of there was found that this group of children in India, sorry, but the average sleep duration was a little over 8.5 hours, plus or minus about 1.35 hours. And so they not only looked at duration, they also looked at different sleep symptoms. So of these children that were part of the study, about 5.6% had sleep apnea that was demonstrated on a sleep study. 10% of parents noted snoring. So there were several, so only about half the children who snored had sleep apnea. Also, a significant number noted restless leg movements. And then 35% had mouth breathing with sleep, which is a symptom of sleep apnea. But once again, a significant number of children with mouth breathing obviously did not have sleep apnea. There's another study of infants and toddlers between 1 and 18 months of age that showed that the average sleep duration in a 24-hour period was 11.65 hours, with about 8.58 hours of that being overnight. And in this study, they demonstrated that 88% of these infants co-slept. They also showed that parents whose children had more frequent nighttime awakenings perceived their children had greater sleep problems than those parents whose children did not wake up quite as much, despite any other symptoms that the children might have. It's also important to talk about digital media and sleep. And so there was a study published also in 2024 of a group of school-age children, so between the ages of 4 and 10, at a tertiary hospital in Western India, that demonstrated that children who used digital media for 2 hours or more a day had significantly higher scores on a measure of sleep difficulties, the CSHQ, which is a behavioral questionnaire. So it doesn't look at sleep disordered breathing symptoms, which we'll get into, but looks more at behavioral aspects of sleep. These children who use digital media 30 minutes prior to bed also had a significantly higher score on this behavioral questionnaire. This study also showed that children who use digital media for 2 hours or more a day also had significantly increased bedtime resistance, decreased sleep duration, increased sleep anxiety, increased night awakenings, increased parasomnias, and daytime sleepiness. So now this part of the talk, we'll move into some basics about sleep physiology. So I'll turn it over to Dr. Felt.
So there are two distinct sleep stages based on specific physiological variables: rapid eye movement sleep, or REM sleep, and non-rapid eye movement sleep, or non-REM sleep. REM is characterized by an activated pattern on the EEG, similar in some respects to wakefulness, but the individual has markedly decreased muscle tone. Non-REM is divided into three discrete stages, based again primarily on EEG. N, or stage 1, is the lightest and often the initial stage of sleep, and N3, which is deep non-REM sleep, has a high arousal threshold and is what stages 3 and 4 used to be called. Slow wave sleep appears to be the most restorative form of sleep and is preferentially preserved in the face of insufficient total sleep duration. Both non-REM and REM play important roles in the growth and development of the central nervous system. In general, sleep-wake patterns become more diurnal, and sleep times gradually decrease from infancy into teenage years, which we'll cover in a minute. In infants, REM sleep occurs at sleep onset, and there is an increased proportion of REM sleep at this stage of development. But by childhood to teenage years, sleep onset is through non-REM sleep, and non-REM occupies approximately 75% of the total sleep time. In teens, other changes occur, such as a decrease in slow-wave sleep in puberty, which continues into adulthood, and physiological shift of sleep onset to later onset times, such that if school start times remain the same, the duration of sleep gets sort of shortened, but the sleep requirement remains the same, which is about 9 hours in adolescence, which we'll cover. Next slide. So here is a depiction of the changes between REM and non-REM during the sleep period, and we can see that the first third or so of the night is primarily in deep non-REM sleep, and that overall REM and non-REM kind of alternate through the night. And in reality, there is a periodicity of this of about 90 to 100 minutes, with progressively lengthening of the duration of the REM periods in the final half to third of the night. And REM is primarily when dreaming occurs. Arousals that occur earlier in the sleep period are times when, for instance, night terrors, where the NT is on the graph, when night terrors occur, whereas nightmares, again, which are related primarily to REM sleep, occur in the latter third of the night. The highest lines are periods when an individual can come fully awake between other sleep stage transitions, and this is really an important concept to remember. Even good sleepers have 3 to 5 what we call partial arousals during the night, but the family may not be aware of these arousals because the individual just readjusts and regains sleep. However, as indicated by the SOA, those arousals are related to the habits at sleep onset and are arousals related to a condition called sleep onset association behavioral insomnia. So here in the US, co-sleeping is less common than other cultures, and we see this problem maybe more frequently than other cultures do. But if a parent is involved with getting the child to sleep as part of the sleep onset habit, then during the night at these partial arousals during sleep, there's a high likelihood that the parent may have to come and recreate the bedtime routine in order to get back to sleep during the night. Thus, it's important to think about the sleep onset habits when you're evaluating arousals during the night, because that may be a good causal link. However, other factors may play a role to increase the risk of arousals, such as sleep disordered breathing, which we'll talk about, sleep restlessness, discomfort from things like constipation or eczema, and other factors. Next slide.
So we'll move into talking a little bit about recommended sleep durations. So according to the American Academy of Sleep Medicine, infants between the ages of 4 and 12 months should be getting about 12 to 16 hours of sleep per 24 hours, and that includes naps. Children between the ages of 1 and 2 should be getting 11 to 14 hours in that 24-hour period. Once again, that includes naps. Children 3 to 5 years of age should be getting 10 to 13 hours, including naps. And then when children get to be 6 to 12 years of age, 9 to 12 hours is the recommended duration. And at this point, most children are not napping. And then teenagers from the ages of 13 and 18, it's recommended that they get between 8 to 10 hours. And so looking a little bit at that, this is a table from one of the studies that we referenced earlier. So this is looking at both at bedtimes, different routines or sleep or bedtime habits, as well as the amount of sleep for the children in this study. So looking at this study, really the youngest children, so I think it might be hard to see. I think it's between the 1 and 3 years age group on the left-hand side of the table. They were the ones that really had the most consistent bedtimes compared to the older age groups. And it was really this kind of preschool age, this like 3 to 5 years, that they actually had the most co-sleeping with parents in this cohort. 75% of them co-slept. And then when looking at the amount of sleep that these kids were getting at night, the largest group of the youngest children, so 45%, were getting over 9 hours of sleep. And as well as that 3 to 5 year age group, the largest group of them were also getting over 9 hours of sleep. However, we can see as children got older, they got significantly less. In the 5 to 10 years age group, the largest share were only getting 7 to 8 hours. That was also evident in the over 10-year age group. So we talked about the sleep guidelines for our American Academy of Sleep Medicine. And these are some sleep guidelines from the Indian Academy of Pediatrics. And so per the IAP guidelines, children between the ages of 0 to 3 months should be getting a minimum of 11 hours of sleep. But it's really recommended that they get between 14 to 17 hours of sleep and generally have about 3 naps a day. 4 to 11-month-olds should be getting a minimum of 10 hours. Once again, that's between 12 to 15 is really the recommended range. and they should be napping twice a day. So fewer naps as they're getting older. 1 to 2-year-olds should be getting a minimum of 9 hours, but the recommended range is 11 to 14 with 1 nap in a day. 3 to 5-year-olds should be getting a minimum of 8 hours, but recommended longer durations, 10 to 13 hours. And about half of these kids are no longer napping at that age. 6 to 13-year-olds should be getting a minimum of 7, but it's really recommended getting between 9 to 11 hours. And then 14 to 17-year-olds should also be getting a minimum of 7 hours. And their recommended sleep range is between 8 to 10 hours. So in addition to guidelines on duration, the Indian Academy of Pediatrics also had some other recommendations, including that consistent bedtime routines and sleep schedules are very important because that kind of helps create an association for children between their bed and these routines and sleep. And they recommend that electronics and screens are avoided an hour before bed. They also talked about safe sleep. The baby should be put to sleep on their backs in a separate crib or cot with tight-fitting sheets and no soft pillows or toys to lessen the risk of SIDS or accidental suffocation. The guidelines were really kind of almost like a frequently asked question for parents. So it also talked about recommendations on managing behavioral insomnias, which we will not be talking about in this talk, as well as parasomnias, which we will be discussing. So now that we've talked a little bit about some basic physiology and some basic recommendations around sleep, we'll move on to talking about sleep disorders. And I wanted to kind of start us off with a case, just kind of get our minds in that frame of reference. So at his 12-year-old well visit, your patient's mother notes on a recent family vacation where the family shared a hotel room, he snored loudly throughout the night. He reports frequently feeling tired when he wakes in the morning, despite getting 9 hours of sleep. So some of these symptoms should be making us think of obstructive sleep apnea. So obstructive sleep apnea or other sleep disordered breathing. So obstructive sleep apnea is defined as recurrent episodes of partial or complete upper airway obstruction that's associated with arousals, awakenings, or oxygen desaturations despite normal respiratory efforts on the part of the child. And there are many symptoms of this. So one of the major symptoms that we always think about is snoring. However, due to children's size and their tone, often a lot of kids can't actually generate enough force to snore. So while snoring can be a warning sign for sleep apnea, not all children with sleep apnea will snore. Other symptoms that are important to think about include sweaty sleep, restless sleep, an abnormal sleeping position. So that's really when they're kind of sleeping with their neck arched back to really open up that airway. Morning headaches, daytime sleepiness, inattention, and chronic congestion with chronic mouth breathing. There are certain populations that are at greater risk for obstructive sleep apnea. This includes children with craniofacial abnormalities, children with certain genetic conditions, for instance, Down syndrome, or neuromuscular abnormalities, and obesity. They're all at increased risk. And any condition that will decrease tone can also lead to symptoms of obstructive sleep apnea. And the sleep apnea is actually more common in very young children and adolescents. It's important to think about some of the sites of obstruction in sleep apnea. So kind of working from the outside in. So the nose and nasopharynx is the first spot that we think about there being some sort of obstruction that's not allowing the air to get through. Then we think about the palate on the roof of the mouth and the oropharynx. And when we think about obstruction in the oropharynx, we're especially thinking about macroglossia or large tongue, which is where children with trisomy 21 or Down syndrome being at increased risk comes in, because often these children will have a large tongue. Lingual tonsils are also another spot where obstruction can occur, and obstruction can also occur at the level of the larynx, at the level of the vocal cords. And it's important to remember that, like I said, not all children who have sleep apnea snore, and not all children who snore have sleep apnea. So snoring cannot be reliably differentiated from sleep apnea just based on history and physical exam. So it has to be diagnosed via a sleep study called a polysomnogram. And this is just a brief refresher on the anatomy and looking at some of those spots where obstruction can occur. So once we diagnose sleep apnea, how do we treat it? So the first line treatment, especially in younger children, is a tonsillectomy and adenoidectomy to remove the tonsils and adenoids that are causing that obstruction. So children will be referred to otolaryngologists, ENTs, for this procedure. As this often requires a repeat sleep study afterwards to confirm that, yes, when we relieve this obstruction, we resolve the sleep apnea. Sometimes this isn't successful, or sometimes it's not thought to be what will be most helpful. So another second line treatment is CPAP, or continuous positive airway pressure, where it's either a nasal mask or a mask going over the mouth and nose that's continuously putting pressure in the child's airways to keep them open. And so those are the main ones. There are a few other treatments that ENT will also sometimes suggest, and that are kind of outside the scope of this talk. They can range from very kind of low level or very simple things such as an intranasal steroid like fluticasone, like some people would use for allergies, to like more drastic surgeries, for instance, to decrease the size of the tongue. So another sleep disorder is called restless leg syndrome, which is more common in adolescents than younger children, but this might not entirely be accurate, and we'll get to why in a second. So the diagnosis of this restless leg syndrome requires the following 6 symptoms. So children have to have an urge to move their legs because there's an unpleasant or uncomfortable sensation. These sensations must begin or worsen with rest or inactivity, lying down, or sitting. And these kids should get temporary, partial, or complete relief with movement, such as stretching or walking, from these sensations. These sensations often occur mostly in the evening or night, and they will cause sleep disturbance or some degree of impairment of daytime functioning. And then this is where it's kind of challenging why we say that it's diagnosed more in adolescents than younger children, because symptoms need to be described in the child's own words. So as you can imagine, it's a lot easier for an adolescent to describe these things than a young child. So the pathophysiology of this restless leg syndrome is pretty unclear, but there are a few different thoughts of what this pathophysiology might be. So one is there's a brain iron deficiency, and this will tie into one of the treatments that we'll talk about in the next slide. Another theory is that it's due to a disturbance of dopamine regulation. There's also thought that's due to genetic factors, as this does tend to run in families. It's important to note that the restless leg syndrome is a clinical diagnosis, so you don't have to have a sleep study to diagnose this. So once we diagnose restless leg syndrome, how do we treat it? So the first line of treatment is avoiding triggers, which could be a lack of sleep, prolonged inactivity, or certain medications, for instance, diphenhydramine or selective serotonin reuptake inhibitors. Another mode of treatment that many times we'll opt for is assessing for an iron deficiency. Like I mentioned, that there's a theory that brain iron deficiency could be leading to this. So checking iron studies, especially looking at ferritin, which is the amount of iron that is stored in the body. And so if there is a deficiency, it would be treating that. And it's important to note that the ferritin that you aim for to treat restless leg syndrome is higher than what is considered physiologically normal. That a child could have a normal, quote unquote, normal ferritin based on lab values, but still could overall be iron deficient. So we actually aim for a level of 50, which is higher than the lower range of normal. Sometimes if you've already tried avoiding triggers, have tried iron supplementation, if that was found to be a potential contributing factor, if these symptoms persist, sometimes gabapentin is used, but that is not very common in children. Okay. So shifting to another set of disorders with another case. So a grandmother calls with concerns about her 8-year-old grandson waking up screaming last night a few hours after he fell asleep. He appeared frightened when she checked on him, and she couldn't console him, but he fell back to sleep quickly. This morning, he did not remember the incident. So this is where we'll start talking about parasomnias. So parasomnias can really be divided into 2 groups. So non-REM parasomnias and REM parasomnias. Non-REM parasomnias tend to be most common in the first third of the night, which is when we have more of our non-REM sleep. And these include night terrors and sleepwalking. REM parasomnias are most common in the last third of the night when we have more of our REM sleep. And the most common parasomnia of the REM parasomnias is nightmares. And it's worth noting that nocturnal enuresis or bedwetting is also considered a parasomnia. It can occur in either REM or non-REM sleep, but that will be outside the scope of our talk this morning. So, comparing nightmares versus night terrors. So, a child that has nightmares, like we already talked about, those are going to tend to be later in the night compared to night terrors, which will be earlier in the night, often within 4 hours of bedtime. A child that's experiencing nightmares often will be very alert or scared or upset, whereas a child that is having night terrors often is more confused or disoriented and doesn't quite understand what's going on. A child when parents go to console them, a child that's experiencing nightmares is able to be comforted by their parents. A child experiencing night terrors is not going to be able to be comforted. A child that has nightmares will remember their dream, but a child with night terrors generally is not going to remember the incident at all. When a child has nightmares, it's often more difficult for them to fall back asleep, especially after having these bad dreams. But if a child has night terrors, they are often able to return to sleep much more quickly. And then we discussed as well the sleep stages that they're in. Nightmares tend to occur in light REM sleep, whereas night terrors are in very deep non-REM sleep. So, how do we manage nightmares and night terrors? So, sleep studies are not routinely indicated for this. They can be helpful if you're concerned that maybe these awakenings are actually not just nightmares or night terrors, but actually representing seizures. There are specific seizure types that can occur overnight, or that the awakenings actually represent awakenings from obstructive sleep apnea. So in that case, you would do a sleep study. But in general, you do not require sleep studies to diagnose or manage these. And in fact, parental education and reassurance are key. Often these can be really scary for parents, especially night terrors. But reassuring them that night terrors are very self-limited. Most children are going to grow out of them by puberty. As an important thing to think about with management of nightmares, they can be precipitated by stress and anxiety. So maintaining good sleep hygiene and treating any underlying anxiety is key. Some children will benefit from reassurance by their parents. Some have a security object like a stuffed animal or a blanket. And some children really benefit from like low-level night lights as well. Certain relaxation strategies and systemic desensitization can also be helpful for this. So then the last parasomnia is sleepwalking, which is where ambulation occurs during sleep. And it has to be this ambulation occurring during sleep along with an altered state of consciousness. As altered state of consciousness is defined as having at least one of the following. So having a difficulty waking the person up, having a lot of mental confusion when they're woken up, having amnesia either complete or partial about the episode, doing routine behaviors at inappropriate times, or having behaviors that are either inappropriate or just don't make sense. Also having dangerous or potentially dangerous behaviors. And so in this case, management is primarily focusing on harm prevention. So for instance, if a child has a bedroom on the second story of a house, having a gate in front of any stairs could be considered a form of harm prevention, so they're not going to fall down the stairs as they're sleepwalking. Or on the first floor of the house, they would have easy access to like the front door, making sure that's locked in a way that the child can't open it. Another way to manage sleepwalking is maintaining good sleep hygiene, which we'll talk about what that looks like in a few slides. And most sleepwalking resolves by puberty as that slow wave sleep decreases, like Dr. Felt mentioned earlier. So another case to move us into our kind of last grouping of sleep disorders. So a mother calls your office regarding her 16-year-old daughter's sleeping difficulties. She notes that her daughter regularly will stay up until 2 a.m. and has a hard time waking up in time to get to school by the 8 a.m. start time. She's often tired in the afternoons when she comes home from choir rehearsal. On weekends, she'll often sleep until noon if she's able to do so. And when she does this, she wakes up refreshed and with good energy. So Dr. Felt mentioned before that teenagers do have a natural shift in their circadian rhythm where bedtimes tend to be later, but this circadian rhythm sleep disorders late phase type is even more dramatic than what we normally physiologically expect. So this is defined as a delay in the phase of the major sleep periods, that overnight sleep period, in relation to the desired sleep and wake up time. So basically, you're going to bed later or waking up later than what you want to or need to. And this is evidenced by chronic recurrent complaint of the inability to fall asleep at that desired time and the inability to wake up at that desired or socially acceptable time. It's important to note differentiating this from other sleep disorders, from other sleep disorders, that when they're allowed to choose their preferred schedule, these patients will exhibit normal sleep quality and duration for age. So if you were to let a child with the circadian rhythm sleep disorder, delayed sleep phase type, sleep as long as they wanted to, they would still get their 9 hours or however much they normally would get. It would just be shifted later than normal. But, and they maintain this very delayed but stable phase of this pattern. And so a way to like assess this is keeping a sleep log, include like a sleep diary, and recording sleep and wake times for over 7 days. And that demonstrates a very stable delay in that timing. And so another part of this definition is that it can't be explained better by another sleep disorder, another medical or neurologic disorder, medication use, or a substance use disorder. So what is our treatment strategy? So first, sleep hygiene. Have these kids avoid naps, because if they nap during the day, that is going to decrease the sleep pressure on them to fall asleep at night. Decreasing caffeine, especially later in the day, because that will help keep them up, as well as decreasing exposure to bright lights, including electronics, later in the day. We know electronics, not only do they keep kids awake because they're playing on them or using them, but also that bright light decreases the amount of melatonin that we produce, so thus not making us as sleepy. Also important with sleep hygiene is to have regular sleep and wake times, and even keeping this consistent between the school week and weekends. Other strategies include light therapy, where children will use a special full spectrum lamp. They will sit beside it that adds about 10,000 lux, and you would have to sit beside it from 30 to 90 minutes each morning to reset that circadian clock. There's also some limited evidence for using melatonin for help with getting to sleep earlier. And then there are 2 other major strategies depending on exactly how delayed the sleep phase is. So if when the child is falling asleep is less than 3 hours after the desired bedtime. So say a child should be going to bed at 9, should be falling asleep at 9, but they're not falling asleep till 11, you would do what we call phase advancement. So in that case, you move bedtime earlier by 15 minutes every 3 days. And then you also move up the wake time. And it's important to move up that wake time as well to keep the same amount of sleep, because that will lead to have the same amount of sleep pressure for them to fall asleep later that night. The other strategy that is used if sleep phase is late over 3 hours is called chronotherapy. So this would be, once again, say the child is supposed to go to bed at 9, fall asleep at 9, not falling asleep till 1 a.m. Instead of pushing the bedtime back, you'll actually advance the bedtime or make it later and later. So what you do is you move that bedtime later by 2 to 3 hours every day, and then make sure that the child is waking up after 8 hours. So then, once again, they have that pressure to fall asleep when they need to fall asleep. And so eventually the idea is that you will move around the 24-hour clock to then have a bedtime at a socially acceptable time. And sometimes light therapy and melatonin can be used together with this strategy to help reset the circadian clock. So talk a little bit about behavioral supports for sleep, which include good sleep hygiene. So when we think about sleep hygiene, there's this acronym, the ABCs of sleeping. So the first is age-appropriate bedtimes and wake-up times with consistency. So this is looking at how much sleep should a child be getting for their certain age and making sure that their bedtimes and wake times will allow them to be able to get that amount of sleep, and making sure that these are consistent. Second is schedules and routines. So I talked a little about the consistency of wake and bedtimes, but also having a consistent routine before bed. For instance, the AAP's brush, book, bed. That these routines kind of help the child get into the mindset of, yes, it's time to go to bed, and helps them transition to bed easier. Location is also important for being in a cool, dark room. Some children do prefer having some night lights, but it shouldn't be nothing too bright, as well as a room that is quiet. Once again, some people do need some sort of white noise or music to fall asleep, but it shouldn't be too loud. It's important that this environment is consistent throughout the night. Dr. Felt referenced earlier the partial nighttime awakenings that we all have. If the environment is the same throughout the night, then it is much easier to just roll over, go back to sleep, and not even really realize that you woke up, as compared to when the environment is different, it causes us to be more awake and be more vigilant. Exercise and diet are also important for good sleep. Making sure that children are getting proper nutrition during the day and are having opportunities for physical activity also sets them up well to sleep. We already talked about no electronics in the bedroom or before bed. And like I said, often this can displace some sleep time, but also the blue light decreases melatonin production. Positivity is also important. Making bedtime and the bed a positive place to be and not something that a child dreads is also important. Independence when falling asleep is also really important. So that's where talking a little bit of those sleep onset associations and a child being able to fall asleep without parental presence is often very important. And also the needs of the child being met during the day. So physiologic needs as well as emotional needs and comfort. And so all of these together can lead to great sleep. So the last little bit, we'll talk a little bit about how do we screen for sleep problems in the clinic. So there's this really useful screening tool called the Bear screening tool as an evidence-based screening tool established in a primary care setting. And it's really important to use a tool like this because parents aren't necessarily going to bring up concerns about their child's sleep on their own unless they are having lots and lots of problems with it. And so this tool looks at bedtime issues, so asking about, are there difficulties with bedtime? How long are they taking to fall asleep? Things like that. Ask about excessive daytime sleepiness. Are they falling asleep in class? Are they falling asleep in a car on a short car ride on the way home from school, for instance? Asking about night awakenings. Are they sleeping through the night or are they waking up a lot? Asking about the regularity and duration of sleep. So assessing for, our sleep and wake times about the same throughout the week. Are they getting enough sleep? And then asking about snoring. As we referenced before, it's not a perfect proxy for sleep apnea, but it can raise our suspicions and cause us to go down that diagnostic pathway. So here are my references, or our references. And thank you so much for your time, and we will answer questions.
Thank you very much for a wonderful session. We have few questions in the chat box, then we'll open the forum for others to discuss. So first question is from Dr. Bajaj. This is regarding restless leg syndrome and the relationship with overactivity. I don't know whether he means ADHD, but overactivity in general. So
Yeah, I'd like to take this question if that's okay.
please.
I think it's a very good question. Thank you. And Dr. Kavade, you're bringing up a good point about what does the overactivity mean. Actually, exercise before bedtime is one of the suggested treatments for RLS. And so just general exercise can be a benefit. Overactivity could bring muscle cramping or that kind of discomfort that might interfere with sleep onset, but it would be different from RLS, which has this component of an urge to move that's very specific and kind of hard for kids under age 8 in particular to really describe to us. And then there's a whole set of similar disorders called growing pains. And the overlap between growing pains and RLS has been challenging, and experts have been trying to differentiate the two. And so it becomes kind of complicated. The third area has to do with ADHD that you brought up, Dr. Kavade. And people are wondering whether there is a central nervous system etiology and overlap between the restlessness, general restlessness that comes with ADHD and RLS symptoms. And so people are considering how to differentiate these and whether things like iron deficiency is a common underlying problem for both conditions. And so I think that overactivity in and of itself doesn't predict RLS or doesn't cause RLS. but it brings up a very interesting question about the overlap between overactivity related to ADHD and the underlying central nervous system underpinnings of RLS.
Sandeep, I wanted to add something here. I was listening to what Dr. Felt said, and one thing we have to be careful about is the contribution of some medications to a sense of restlessness. So, for example, I have seen in some fields, psychiatrists or others might place a child or an adolescent on an atypical antipsychotic or some sort of sedating medicine, or they may be taking it anyway for depression. So, antidepressants, antipsychotics can cause a sense of urgent feeling of can't sit still, akathisia, they call it. And while that's more common during the daytime, it can also be if they're taking it and they're trying to fall asleep, that the need to move your feet. And that can also be sort of confused with RLS. And so we have to be mindful of the medicines we give to help a problem might be compounding that problem. So just that little bit, and thank you.
Yeah, thank you, Dr. Soares. I'm going to come down, just skip one question to come down to the can growing pains contribute to sleep disorder? And then we'll go back to the teenage question. Growing pains is differentiated from RLS symptoms by when it's occurring. Growing pains can occur any time of the day, whereas RLS symptoms are more specific later in the day prior to bedtime with that urge to move. And so, yes, growing pains can contribute because it's uncomfortable, but it isn't as specifically associated with insomnia, with initial insomnia and trying to get to sleep.
Next question is from Roshni Sodhi ma'am. The question is that most teenagers complain that even if they try to have a routine, try to sleep, go to bed early, they can't fall asleep. So what could be the issue? And I find a similar thing with my son, who is now 13 years. Next day, some anticipation, some mild excitement is there, some event is anticipating, maybe an exam, maybe even small thing. He finds it very difficult to sleep on that night. So what could be it and how we can help them?
Yeah, so I think you're definitely seeing some of that natural shift in the circadian rhythm that Dr. Felt and I talked about. Children, when they become teenagers, their circadian rhythm is naturally shifted to want to fall asleep later and wake up later. And it's actually here in the States, there is a movement in some areas to try to actually make high schools start later to allow teenagers to have more of that time. Because Dr. Felt, you can correct me if I'm wrong. I don't feel like there's really no medication other than perhaps attempting melatonin or something like that to help increase that sleep pressure at onset to really treat that per se.
I agree. And the one thing I would add is that it would be really helpful to take what's called a sleep log and to look at the pattern of sleep initiation and wake times across, say, a 2-week period. And oftentimes, teenagers will try to make up for sleep and oversleep on the weekend and like sleep until noon or 1 p.m. And then when they're asked to go to sleep on Sunday night for school on Monday at a time of 10 or at or so, they can't because they've overslept and their sleep pressure is diminished. And so keeping a regularity of schedules, weekend to weekday, can be helpful to keep kids on track. And we haven't also talked about sort of innate genetic differences between individuals and families, of people being more of a night owl, that even later times of sleep onset, or a morning lark, people who tend to wake up early no matter what time they went to bed. And that can play a role as well. But I think my recommendation would be to help the teenager to try not to shift so much on the weekends to try to stay on track.
Very well.
The other thing, Sandeep, I will add in is that you had mentioned about your own son and the anticipation and activities. Sometimes ruminating about either anxiety-provoking situations, I have a test tomorrow, I have a performance, or the excitement, the stimulation from there's a picnic, there's an outing, can lead to difficulty in settling. And I always suggest, at least for teenagers, they are cognitively adept enough to practice some mindfulness and be in the moment and think about where they're at and ground themselves and start using some of those mindful techniques to go to sleep rather than letting their mind race ahead to the future, where really, the need of the moment is ground yourself in the present. Look at your environment, be mindful of the darkness, the quietness, the feel of the clothing, and start to settle down and not let your mind run ahead to tomorrow.
Exactly what I just want to add on the same thing what Dr. Neelesh say. It's important is the soundness of the sleep rather than the hours of the sleep. That is one of the things what we are considering when we are tackling the adolescent, because the 1 or 2 hours plus minus maybe the okay and overcome by them with the soundness of that sleep.
One question which we find is that here in some of the parts like Pune, Bangalore, we are very IT centric people, and they have their schedules which are linked to US. So they are working late at night online. So can this be affecting the rhythms of children too? Because many families, both father, mother are online, work from home, and that schedules are overnight. So how this can affect for children and how can we help them?
Deanna, do you have thoughts?
I would say certainly if the parent is working in a room that's like near where the child is and there's like the light and the sound, that could certainly kind of impact especially the falling asleep or potentially waking up as well. As far as recommendations, the Dr. Felt can add on to this. I would say potentially if there is an ability to like separate those spaces more, I know it's not always possible. But Dr. Felt, I don't know if you have any other thoughts on that.
Yeah,
I was
I think that,
also thinking, go ahead. Sorry, Dr. Pal.
I was only going to say quickly that I think parents are important models of good strategies around personal health and sleep health. And so for parents to be modeling um, a good balance between their work life and their family life and their sleep, I think is important, as well as this um, idea of no screens the hour before trying to go to sleep, because the light from the screens really affects melatonin production, our internal melatonin production, which affects our ability to get to sleep. And so I don't know that parents' online use is contributing directly physiologically to the child's sleep, but I think at least through modeling and kind of setting the stage for good sleep health and recognizing the importance of it is a factor. Dr. Suarez, what would you add?
Yeah, I think that also, sometimes it's not possible, depending on the size of the home and the number of people, to separate the parents who are working. But you can try and create some sensory barriers. So whether they have small headphones that the child can listen to certain tones of music, there's some research that suggests that certain frequencies are more calming and stuff, and maybe playing white noise or something. So it's reducing the parent in the same room or next room talking on the headset to a client, and then use little eye patches like they give you sort of sometimes on airplanes and stuff. Real simple things to at least block out some of the possible stimuli. But I agree with Dr. Feld. It's ultimately how to handle and manage your own rhythm, because there are children who will sleep to the most chaos. And it's not that, stimuli are always associated with sleep reduction. It's how you train your brain and how you desensitize ultimately that leads to successful sleep.
We have a question from Dr. Archana. Like we discussed for ADHD, even autistic children, especially with sensory issues, have a lot of problem to falling to sleep. So, what are your suggestions for them? Yes, what parents can help them with?
Yeah, we have a group, the Autism Speaks Association here in the U.S. that has a whole um, webpage on sleep, because sleep is such an important affected area for kids with autism. And in fact, individuals with neurodevelopmental disabilities in general, like 70 to 80% of them have sleep problems related to their a degree of sensitivity. And let me turn it to Dr. Pennewitt for some ideas, and then I may add on.
Yeah. So we know that children with autism really thrive on routine. So making sure that that bedtime routine is very consistent, and wake and sleep times are consistent throughout the week. That can really help with falling asleep. Um, there's also some evidence that children with autism actually make less melatonin than their peers without autism. So that could also potentially be another strategy that families could use, even just using small doses of melatonin about a half hour or so before the desired bedtime to help increase that.
So, and the next question is regarding sleepwalking. Do we need to treat it and how?
So, sleepwalking, like I think I discussed on that slide, really it's more about harm reduction. It's not dangerous in and of itself. It's just if the child could get into a dangerous situation like falling downstairs or something like that. There's no medication to treat it.
And there's some good strategies, Sandeep, in terms of if a child leaves the room or attempts to walk, we can use conditioned responses to try and get them to redirect. And it also helps. So I have there's some eloping, children with autism who'll elope from their bedroom, sometimes elope from elsewhere. You can get those little, those light beams that you break it, right? Sometimes when you go into stores or somewhere else, you'll hear a ping or it'll create a circuit, and it's so easy to do. Basically, it's a receiver and a thing. And you can actually use behavioral training. So every time a child, attempts to leave a space, if they get a certain stimulus, then it can be redirected to return to said space, right? It's not the easiest if you're deeply in a NREM sleep and you're truly sleepwalking, but a lot of young children and others will leave sort of half asleep, but they have these little things. I want to go down. They wander to the TV. They wander to get a snack. And sometimes it's good to reinforce staying in the room. It won't
And I
work for somebody who's oblivious because it's really hard to get through to them. But some of these kids are actually, they wake up instead of falling back asleep. They start wandering. But if they're like, that's that signal for me to go back in, that reduces the need for the parent to get up and run there and try and redirect them back.
For kids who are sleepwalking, they are more likely to do common behaviors like turning the knob of a door, etc., or even unlocking a door for a bit older person. And so the safe proofing should really consider things that are out of order. So you put a chair in front of a door, or have a lock that's high up on a door. We've had kids in our sleep clinic that in an unfamiliar location, there have been reports anyway of individuals in an unfamiliar location walking off and having great injury, like walking off a balcony, because of they're unaware of their surroundings. And so safe proofing is the number one strategy. However, there are some medications like clonazepam, I think, some benzodiazepines. I'd say for kids, it's really rare because most people will grow out of these parasomnias with time. So it's really rare, really, really rare that we use medications.
Very nice suggestions for sleepwalking. And the next question is like you told about circadian rhythm changing in teenagers. So the question is from Dr. Roshni. Does it matter when these 9 hours are complete? Or they sleep at any later, but they wake up later, but they manage those 9 hours. So is it okay at any time? Or a good rhythm, let's say sleeping at 9, waking early or something like that is better? Or
So I personally, I am unaware of any research that says that if that's the person's circadian pattern and it's fitting with their daytime activities, if that's their pattern, that it's okay to be on that 1 a.m. to 10 a.m. schedule if it's not interfering. Shifting, so there is work for people who have shift work and are shifting a lot between different shifts, that can be challenging and affect their functioning at work if they're trying to make that shift in their circadian work schedule very frequently. But if that 10 a.m. to 1 a.m. to 10 a.m. schedule is set and working for the individual, it's probably not physiologically harmful.
this is about, if we discuss about teens, this is about a toddler. So mothers sometimes come worried to the OPD that child is sleeps at 2 a.m. and intermittently wakes up for feeding and not having a good pattern. So how to help these toddlers fall to sleep? And sometimes what I observed is another, when a child gets admitted, young infant or for 1 year, 2 year, next 1 month, that because of the fear, many children have problem with sleep, 4 5 days of hospital admission. So how can parents help during that time to get them to rhythm early?
Deanna, do you want to take that?
Yeah, so for the last part of that question, like for instance, like a child like after hospitalization that is having a hard time getting back to sleep, really trying to establish that normal routine as quickly as you can is really the most important thing. It might be a little challenging, especially at first, but getting that child back to what they're familiar with is really going to help with that sleep initially.
And sometimes, Sandeep, even though we suggest there should be more independence in sleeping, there's some exceptions, an illness, a hospitalization. If for a brief period of time the parent wants to co-sleep again, especially if they had not been, but just for comfort, because certainly the anxiety of having had the hospitalization has the child dysregulated. So you can sort of bend that rule a little bit. You don't have to be rigid and say, no, they have to sleep by themselves. Slowly get them back and then slowly fade that stimulus over time. Regarding the toddler one and the feeding, I think we'd come back to the question of, does the child need it for nutritional purposes? Because there are some times when, at some point a toddler is breastfeeding for comfort and less so for nutritional purposes. And then the question becomes, and certainly it's a cultural thing, right? Different cultures have different sort of expectations. But if it's interfering with the parent's sleep, and it's not got a nutritional component, then you have to try and teach the toddler alternate ways to self-soothe and calm that they can do with themselves, right? Whether that's hugging a soft toy, listening to some certain, rhythms, things like that. If it's nutritionally essential, that's fine. But, even if it's culturally accepted, it is never a great thing to have a parent have absolutely disrupted sleep because their functioning also gets impacted and they're not at the best for their child.
One
And
suggestion
so
is
I totally agree. And I would say that the waking at 2 would lead me to ask, how is the child getting to sleep? And maybe the change that will really help the family will be to think about weaning in general, but changing the sleep onset habits so that the child's learning to get to sleep from not while nursing, but even if nursing is maintained, that it's separated from the process of getting to sleep, if that makes sense. That will help eliminate over time the arousals that require the parent to recreate that nursing to get to sleep.
one suggestion which I give my parents is, if you're trying to change the habit of not feeding for sleep, try it during the daytime when the child is napping. If the child gets in the habit of sleeping without feeding in the day, gradually you can pass it on to night. At night, the child is anxious and you trying to teach him something new is slightly more difficult.
Totally agree. Excellent point.
Mouth or oral breathing, the how we can it hamper the sleep pattern, and if some child is having repeated oral breathing, do we need to treat it?
So here, there's increasing evidence that mouth breathing can be a subtle symptom of sleep disordered breathing. And so to further investigate whether there are other symptoms that could lead one to suggest a polysomnogram to evaluate for sleep disordered breathing. Otherwise, it wouldn't, other than maybe the mouth being dry and waking to get a drink of water, I'm unaware of other disorders that it would incur.
So many times polysomnography may not be available each place. So my advice is the how the child wakes up in the morning related to whether he's fresh or whether he's irritable. Does it have a relation to the quality of sleep?
Deanna,
So
would you like to take it?
yeah, so often when the child is waking up and they're still very tired or more irritable, that is indication one, they might not be getting enough sleep, but also that's another indicator of that sleep disordered breathing. That would make us suspicious for sleep apnea, that they aren't having that sustained restful sleep throughout the night, that they're having these little pauses in their breathing that might be causing them to wake up or not sleep as fully.
And Sandeep, sometimes if there's lack of access to sort of equipment or experts for PSG and things, sometimes it's really helpful for the families if they have, they're awake and they can record the sounds of the child at night. And there's certain very classic patterns of how an apnea sounds, how snoring sounds. And if they can capture that and share it with the doctor, that helps in triaging whether or not they need to seek out a sleep specialist versus not.
And it might be that plus maybe if it's a heavy mouth breathing and maybe a mouth breather even during the day, going straight to otolaryngology to evaluate whether tonsils and adenoids are enlarged might be the correct decision. Between the ages of 3 and 7 or 8 is the highest risk period for enlarged sort of lymphoid tissue, tonsils and adenoids, over the area that is sort of the real estate that's available for it. And so it is a high risk period. So a mouth breather in that period, and if you don't have access to a PSG, then going straight to an otolaryngologist might be the correct next step.
So very nice discussion, and we have a feedback from our current Adolescent Health Academy chairperson also, who says that it was nice discussion and proud of AACCI. So thank you all the experts for such a wonderful session, followed by a Q&A, and which has solved doubts of many of our doctors. I would like to thank both the experts, Dr. Barbara Trufelt and Deanna Pennewitt, for giving their valuable time and having a wonderful presentation as well as knowledgeable feedback during our discussion. And also, I would like to thank Dr. Neil Suarez sir for having been the backbone of this total international webinar series. He has been one of the pillars, and he is being the guiding light for helping us through these 12 sessions. Thank you very much, sir.
It's my honor to be with an amazing team from University of Michigan. We have more amazing topics coming up. Next month will be torch infections and neurodevelopmental consequences thereof. So Dr. Pollack and I will be glad to join. But I want to thank both Dr. Pennewitt and Dr. Felt for being so amazing on today's session and giving some of their weekend to us.
So I would like to thank all the experts and the scholars who attended. Thank our co-host Dr. Samir Shah and Fatibha Ma'am for this wonderful opportunity. And as Dr. Neil said, we have more topics coming, more international speakers who will be discussing, and it helps that it gives a very different perspective in many times in terms of research and clinical evidence, because we have experience in many things, but clinical data and this is something which is lacking in our Indian setting, which is held by the experts from abroad, especially like Dr. Neil Suarez and other team who comes. So thank you very much for their valuable time and inputs.
Thank you.
Thank you so much for having us.
Bye.
Thank you, and we will meet again on the same date of the March, 8th March.
8th March.
8th March. Okay. Bye.